Hey students, you're listening to Chapter 31, Assessment and Management of Patients with Hypertension. And hypertension does have its very own chapter. That's because it's extremely common and it leads to cardiac conditions. So by the end of the chapter, you should be able to define what a normal blood pressure is and then the different categories of abnormal blood pressures. Identify the risk factors for hypertension. Describe treatment approaches for hypertension, including lifestyle modifications and medication therapy. Use the nursing process as a framework for care of a patient with hypertension, and then describe hypertension or hypertensive crises as well as their treatments. So hypertension is simply high blood pressure. It is the most common chronic disease in the United States and most common among adults, but also is now being seen in children. Here's the different classifications for the adults ages 18 and over. Hypertension, especially if the systolic is elevated, will increase the risk of death, stroke, and heart failure in people over 50 years of age. So as you have an adult aging, you want to pay closer attention to their systolic blood pressure. Yes, the diastolic is important as well, but a lot of times the systolic gets dismissed because it can vary based on activity, exercise, rest, anxiety, pain. There are so many different variables that go into making it elevated. If you have a patient that's around 50 years or older, you really do need to start paying more attention to the systolic as well as the diastolic. But you can have a normal blood pressure, a blood pressure that's considered pre-hypertensive. Your patient can also be diagnosed with hypertension, and that is further divided into stage 1 and stage 2. There are many different factors that are involved in the control of blood pressure, which is why there are so many different treatments. Before you can treat them, you have to figure out exactly what the cause is. The major risk factors are listed here. Some of them are modifiable, some of them are not modifiable. Hypertension will often accompany other risk factors for atherosclerotic heart disease. So you can have dyslipidemia, which is an abnormal level of fat in the blood, obesity, diabetes, metabolic syndrome, and sedentary lifestyle are other risk factors. And metabolic syndrome is whenever weight is gained around the midsection. And so whenever you're looking at your patient, they can have what you would consider normal sized thighs, legs, arms, and even chest, but then they have what most people refer to as a beer gut. When you do your patient assessment, you're going to get a history and physical. You'll want them to have a retinal exam because hypertension can affect a patient's vision. You can get basic blood chemistry, check their electrolytes and urine function. You can get a urinalysis and see if they're dumping any protein in their urine or ketones. Your blood chemistry will also give you a glucose level, so you can see if they have maybe undiagnosed diabetes or elevated blood glucose, and then do an ECG to look at the electrical conduction of their heart to make sure that they don't have any current damage or blockage or dysrhythmias going on. As far as medical management, you want to maintain a good blood pressure, so you want it to be less than 140/90 millimeters mercury. If you're an adult that is not the 65 or under, so 18 to 65. Older adults can have a systolic that's a little bit higher, and their blood pressure should be below 150/90. So your systolic, there's a little more give there. Lifestyle modifications are the easiest way to try and have weight loss. And if they can have regular physical activity instead of a sedentary lifestyle, that will help. For heart health, it will also help to reduce the weight. Changing their diet, so a DASH diet. So you're going to have a diet that's low in sodium. Sodium intake of no more than 2.5 grams daily is recommended for a patient who has hypertension. And if you give them a specific goal that they can measure, they're more likely to comply. So you can tell them you shouldn't have more than 2.4 grams in a day, and you can divide that out even to meals or snacks. That way, and then you can also show them how to read the nutrition facts on the box to find out how much sodium is in each serving, what is a serving. They might become just more aware of, maybe they thought they were doing well because they were buying all low sodium foods. Low sodium does not necessarily mean that it has a low sodium content. What it means is that the sodium content is lower than the normal version. So if you buy low sodium dressing, it isn't without sodium. It just doesn't have as much sodium as the regular. So if you buy Wishbone Ranch and Wishbone Ranch light sodium, it just has less than the regular ranch. Doesn't mean that it doesn't have a lot in it. And patients don't understand that, especially whenever low fat's the same way. And they just see low fat, low salt, and they think, oh, it's good for me, when it might not be. They should reduce alcohol consumption. They don't necessarily have to eliminate it, but if they do consume a fair amount of alcohol, they should reduce that. Part of it is so that if they're drinking alcohol, they're not drinking water, and they need to increase the water intake. As far as pharmacological therapy, depends on the patient. The whole purpose is to decrease peripheral resistance and decrease strength and rate of myocardial contraction. You might want to decrease blood volume as well. If you want to decrease blood volume, then diuretics work great for that. They can also get ACE inhibitors, beta blockers, vasodilators, calcium channel blockers. There's just so many things, ARBs. The cardiologist or their physician, if they have a general practice physician who starts to care for it in the earlier stages, they will determine what would be best for the patient as pharmacological therapy. As a nurse, you need to make sure the medication is administered and the patient understands why they're taking it, what it does, any side effects. If they have stage 1 hypertension and they're African American or they're over the age of 60, they will generally get a calcium channel blocker or a thiazide diuretic. Thiazide diuretics are great because they reduce the circulating blood volume, and it will in turn reduce their blood pressure. It also might make them void more, so they do need to be aware of that. If you're under 60 or non-African American patient, then they can give you an ARB or an ACE. They start at the lowest dose that they can, and then they will adjust upward. They don't want to start at a higher dose and go downward, because if you become hypotensive, then you can fall and have other complications. So they'll start at a low dose and gradually work the patients up. Sometimes our patients have to be on multiple medications to control blood pressure. And again, it's very patient specific. It's something the physician will determine. Your job as a nurse is just to make sure that you monitor for any kind of side effects or complications because of the medications, and make sure that the patients get the education that they need. And give them buy-in, make them responsible, because the more responsibility you can put on them, the more compliant they will be. As far as what you can do as a nurse in your assessment, get a history, do a physical, assess for risk factors, assess for any current signs and symptoms or any history of signs and symptoms, do peripheral pulse checks, do an apical pulse check. You can do an apical radial check to see if they're consistent. Look at their personal life, psychosocial, environmental factors, financial factors, anything that could affect their blood pressure, their ability to be compliant with their medical regimen that has been described, just anything that could affect nutrition or exercise if you're trying to change that. You want to look at potential complications, because if you don't have your hypertension treated, you can have a lot of complications. You can actually have an MI. Hypertension can lead to hypertrophy of the left ventricle, and then you don't have good ejection of the blood volume in the left ventricle, which can lead to other problems, and you can have pulmonary problems then. Hypertension can lead to heart failure, can lead to TIAs, which are like little mini strokes, or an actual cerebrovascular accident, a stroke. It can lead to kidney damage, chronic kidney disease, renal insufficiency, and then the hypertension can cause retinal hemorrhage and blindness. As far as planning for goals, you need to understand the disease process and treatment so that you can explain it to your patient. Your patient needs to know why it is so important, because so many people have hypertension. It doesn't necessarily get the attention that it needs so that you can prevent the more complicated cardiovascular problems. They need to participate in a self-care program. They need to be involved in the planning and goal setting with their change in their diet, their exercise. They need to be monitoring their own blood pressures. So they need to monitor their blood pressures before they take their medications, and they need to write that down so that they know what the blood pressures are every day, and they can see if it's trending up or if it's trending down. If they're having any symptoms, they need to write the symptoms down, and they can write it down, just have a daily log of everything that goes on. And if you're having symptoms, if you called the doctor or not, if your medications were changed, they need to track that, because this is going to be a chronic condition that they have to monitor the rest of their lives. Nursing interventions, be their cheerleader, reinforce good lifestyle changes. Be supportive of lifestyle changes, even if they're baby steps, even if it's a little thing that they did. It might be little to you. They might try and dismiss it. Really encourage it, because every little step accumulates into bigger steps. But if they don't take the first few little steps, then they're not going to accumulate and have bigger steps. So they need to have that buy-in. They need to take their medications as they're prescribed. And if they don't like the side effects, because you can have side effects from blood pressure medication, blood pressure medications. Men, you can have erectile dysfunction from their medications, but if you have hypertension, you can have the same thing. So it's something that they just need to address with their physician. Some medications can cause them to have to go to the bathroom, or if it's a diuretic, and so then they're getting up and going to the bathroom all the time. And they might not like that, or they might have incontinence if it's difficult to get to the bathroom. Some might make them dizzy, some might give them some sort of a cough. You just really need to figure out what's going on with them, why they're not adhering. And they are responsible. They need to be held accountable. Okay. As far as evaluation and outcome, how do you know that they have been learning something and they can take care of themselves? First of all, their blood pressure is better. So they can teach back, tell me what you learned whenever we talked about a DASH diet. Tell me what you learned when we talked about an exercise regimen. What have you done to be able to exercise more? What are you doing to increase your endurance? And you can also, you can have them give you their blood pressure log to show that they've been doing their blood pressures at least once a day before they take their medications like they're supposed to. You can draw labs and see if their labs are stabilized. You can ask them about signs and symptoms of hypertension or cardiac dysfunction. You can do your own assessment and see if there's any changes, if there are abnormals before, if maybe now they don't have abnormals. So there are objective and subjective ways to look at the evaluations. Okay. They should not smoke. If they do smoke, ask them if they're ready to stop. Give them different ways that they can and cannot stop smoking, because some people want to just go vape, and that isn't going to be the better option. And some people just don't want to stop smoking. And if you're asking them to change their diet, increase their exercise, and stop smoking, and limit their alcohol, Those are major lifestyle changes you're asking them to do all at once. So you might have to barter and bargain with what they should change now and what, can wait. And honestly, whatever they're willing to change is what you should go with. If they're absolutely not going to stop smoking, then don't harp on them on stop smoking, because then you're not going to get anything accomplished. But if they're willing to maybe modify their diet, focus on that. That's great, wonderful. Once you have that established, now are you willing to talk about stop smoking? No? Okay, well, let's talk about exercise. So, you're going to have to work with your patients. Otherwise, you're not going to get anything accomplished. And getting something accomplished is better than nothing at all. Make sure they're not having any complications. Again, what are their signs and symptoms? When you do an assessment, what do you see? As far as the older adult, just with any chronic disease, expense is always an issue. They generally have a fixed income. Sometimes they don't remember if they have dementia or Alzheimer's even in the early stages, but there are ways that you can address that. With older adults, as long as they approve, because they're still alert, they're still able to make their own decisions, but you can involve a family member, a caregiver, a loved one that might be seeing after them, taking them shopping, and you can educate them as well. If you have someone making their meals for them or assisting them in their shopping, they need to know what is and is not okay, so that they're not buying them things that they shouldn't be eating. As far as hypertensive crises, there are two types of crises. You have the emergency and then hypertensive urgency. So in a hypertensive emergency, you have a blood pressure of greater than 180 over 120 millimeters mercury. Blood pressure needs to be lowered immediately. Otherwise, you are going to have damage to your heart, your lungs, your kidneys. Hypertensive urgency, your blood pressure is definitely elevated, but there's no evidence or signs of immediate target organ damage. So they would be treated a little bit differently. If you have a hypertensive emergency, patient comes to the ER with that type of a blood pressure, the initial treatment and goal is to reduce the mean arterial pressure by 25% in the first hour, with further reduction over the next 24 hours. You don't want to go too fast. So you want to go quickly, relatively, but you can't go too fast. Because if you go too fast, then you're going to cause hypotension in a body that has adjusted to hypertension, and you could actually cause a stroke or a heart attack. And that's what you're trying to prevent. The medications you give are going to be IV. They are going to be vasodilators to try and relax and open up the vessels, which will decrease the pressure. And most of it's done on a drip. You will do frequent monitoring of the blood pressure, generally at least every 15 minutes, and then frequent cardiovascular status. Most of the time they're on continuous telemetry or ECG readings. Hypertensive urgency, don't necessarily need to treat with IV medications, or maybe like you could do IV push if you had to. They do have labetalol IV push that you can give initially and then give them oral medications to try and normalize the blood pressure. But you do want it back down to normal within the first 24 to 48 hours. These patients, you're also going to monitor their blood pressure closely, monitor for signs and symptoms. They can also be put on telemetry or continuous monitoring. And then you want to make sure that they don't have any organ damage. So make sure that they aren't retaining fluids, that their lungs are clear, they're perfusing well, they have good pulses, good oxygen saturation, they don't have edema, they're voiding.